somebody give me something. Okay, they're coming in for their 3-year well check. What are 7 things that we need to educate the family on? Okay, let's see if they're on their vaccine schedule. When are we anticipating they need vaccines? Great.
Their weight and height.
Oh, let's talk about their weight and height and how they look on the growth chart. Good. Are they doing great? What else?
Their developmental.
Okay, so developmental, that could encompass their fine motor, their gross motor, their language skills. That could probably count for 3 different things. Okay. What else?
Safety.
Safety. Great. What else? And you're not just gonna write safety on there. You're gonna tell me specifically. Safety instructions for a 3-year-old would be blah, 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 right? Fine motor development for a 3-year-old would encompass blah, 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 blah. Okay, you got one more. What else? Nutrition. Great. We're clear? You're not just gonna write nutrition though, right? This child should probably consume 3 meals with several snacks throughout the day. They should be getting a variety of food groups, which would include blah, 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 blah. Am I making sense? This here is gonna be on the same child you just told me about in question number 1. So you are gonna need to know the age of the patient, the sex of the patient, their height, and their weight at a minimum, okay? You will go to this website and you will be able to print a growth chart. And then you will plot the kid's height and weight on a growth chart. If you have questions, I am happy to help you plot that. It's pretty self-explanatory. It's usually the age of the patient, the height or the weight here. So if they're 3 years old, you go to the 3-year mark, you head up to whatever their weight is, and that's where the dot will be. And then you follow it across to see what percentile they're in. Once you see one, it will make sense to you, okay? That's just for practice. And then this, you're gonna wanna just take a piece of paper with you. You're gonna list the age of the patient that you saw that day, the reason for their visit. And I just like to make sure that, I just see what you got to see that day mostly, that you're getting a decent variety of patients. Okay? These are easy points is what I'm saying. If you answer the question. Questions on this assignment? When is it due? Monday. Lastly, so some of this is 5 questions. This should be so easy for you guys if you take the time to answer the questions, okay? What are the roles and skills of the school nurse? That can be a conversation that you have while you're there, but I would encourage you to also look up that question before you even go. So you have an idea of what you're expecting the nurse to tell you, but they may have some other insight of what they're actually getting to do versus what you're reading, okay? Legal ethical issues, I'm sure the nurse will probably discuss that with you, or you can probably think of many legal ethical issues that we face in the world of pediatrics, okay? This year talks about what were the students you saw, how many did you see, what was the age, what did they come to the nurse's office for, what did you guys do for them? This year is more about nutrition. So you're gonna develop a menu. It's gonna tell you exactly breakfast, lunch, snack. If a school-age child, you're gonna make up a menu of what you expect them to eat. It's just for you guys to get practice. You're not just gonna tell me they're gonna eat a strawberry, or you're gonna tell me exactly how much. 3/4 of a cup of strawberries, a cup of milk, 4 ounces of salmon. I don't care. I'm just making this up off the top of my head. So, clear? Okay. And then again, feedback, what did you learn, what skills did you do? This is like elementary type work, easy points. I like you to focus when you're at clinical, being at clinical and doing clinical things rather than being bogged down with clinical work. Of course, I have to have some clinical work because that's a requirement, but this should not be that stressful where you guys feel like you can't function at these clinical sites because you're so focused on paperwork. Okay, questions about any 3 of those? I am not gonna waste time talking about hospital paperwork because I will talk about that on the first day at the hospital with all of you. And I will post an announcement probably late this week or early next week those of you that are coming to clinical first, about where to park, how to get your parking tag, what needs to be completed, what you need to bring with you, so on and so forth. Okay, we do have to pay to park at Mizzou. It should be cheaper than it was last semester, and we're not gonna have to park as far away. If you choose to carpool, which is probably not a bad choice, whatever car you guys are taking to the clinical site has to be the car that is registered through MU Parking, and I will give you instructions on all of that. So if you guys wanna split the cost, you guys can all jump in the car together and split it up. I wanna say it's between $8 or $9 a day. And so if you guys, you have to pay per day, so you only have to go 3 times. So if you split that cost between a group of you, it should be relatively reasonable. Last time we had to park behind the football stadium and walk into the hospital, but our parking lot is a little closer to stuff. Okay, questions about any of that? Okay. These are good to be put away. Yes.
Did you see this one?
Oh, no, I didn't. What are those?
I can send you the pictures. They're the sign-up sheets.
Perfect.
Did you get it? Olivia has it.
Thank you so much. You guys wanna know what school you're headed to?
Yeah.
Any questions about your first quiz?
Is that how, like, I'm just more worried how to study for the test.
What do you mean? Tell me more.
I don't know.
It's the first test is always scary. Yeah, the first test, you just don't know how it is. Do you feel like your questions on the quiz were very reflective of how you'll ask questions on the quiz?
Similarly, yeah. We're gonna cover a lot of stuff today, though. We have more to study, is what I'm saying. We may start on exam 2 information, and next week it will be exam 2 information covered, because I won't see you guys for a while after that. Okay?
So we're gonna just blow through some stuff.
Yep. So, I'm gonna start with the intro to PEDS lecture. I wanna preface this with saying that a lot of this information that I cover, I will probably skip some slides because I'm going to cover it again in growth and development. I'm not gonna sit here and bore you and hear me say it 18 times today, okay? Alright, did you guys do some looking ahead, so you're gonna be interactive with me today? Yes? No? Alright, well, we'll see, yeah.
Miami has had a fever. No, I was still fine. Ron is fine. So I think someone from school, he was
Okay, we're gonna start with this video. Everybody, I can't make it bigger, so you're just gonna have to deal with this little clip here.
Josie was 18 months old. She had brown eyes and light brown hair. She loved to dance and had just learned to bounce on the trampoline with her older siblings, Jack, Riley, and Eva. She had just learned to say, I love you.
The kid gets older, education through that, good. Shut up. Okay, you're gonna be an advocate. Our goal, right, is to promote health. Our goal is to promote well-being in the child and in the child's family. It's wise that we make good, trusting relationships with these people, because we're probably gonna be seeing them again and again and again. Or if a family and a parent doesn't trust you, do you think they're gonna want you to take care of their kid? No. So it's very important that you're establishing that good rapport with people, and even just us in the hospital when we're meeting them for the first time. If we go in and we set a bad impression, or we make the parent upset, they're not gonna want us to come back in that room. So just learning how to develop those relationships and communicate with people, huge. And then in kids, I talked about most kids are healthy, so we're doing a lot of disease prevention and health promotion, right? Other things, we're supporting families, and then in kids, we talk a lot about anticipatory guidance, what can you expect as your kids getting older? How do we keep them safe, those types of things. I'm gonna skip this slide, you are welcome to skip it. Say, qualities of a good pediatric nurse. So the good pediatric nurse must be a good observer. What does that mean to you guys? Like what's happening with the patient, or observing the family and the interaction with the kid. Okay. What else do you observe? Any minute changes within a child? Okay, any assessment changes? What else do you observe?
Personality of the baby, or the baby child.
What else? When you go in a room, what are you looking at?
The baby, or
Just
the child acting.
How the child acts. What else are you looking at?
Parents.
Right, is the room safe? You can go in a room and it looks great. The child is acting well, the parents are appropriate, everything in the room is safe. You can go in 3 minutes later, kids are really creative. They like to push the buttons on the bed. They like to swing from the ivy poles and do whatever they want. So, I encourage, how often should you run on your patients? What do you think? At least hourly. Who said that? You betcha. Okay, you wanna be honest, you wanna be truthful, that's pretty straightforward. You wanna be sympathetic, kind, patient, cheerful. No pediatric patient is gonna want you to walk in the room. Hi, I'm Mindy, I'll be your nurse today. I'm gonna give you some meds. Got any pain? Great, see you later. Push call light if you need something. You think a kid's gonna respond to that? No. Who's that grouchy lady? Ah! They're still probably gonna scream at me, but, so, you gotta be positive, you gotta be cheerful, you gotta smile. I know we have masks on, but you can still smile. You have to get on their level, remember me talking about that? The cheerfulness in your voice, you wanna make eye contact with kids. Us looking down at them is threatening to them, so we wanna get on their level. You must love to work with children, and there's a caveat I always like to add, you must also love to deal with parents. That's probably the hardest job of pediatrics is dealing with parents. The children, they're fabulous most of the time. You wanna be interested in involving family in the care, you need to be able to provide teaching to children and their families. Family-centered care, you're not only talking about their family care, but if we have a patient, let's say in the hospital that's admitted for weeks at a time, you're also coordinating that care with the school. How can I keep, I know you're a nurse, but how can I keep this kid up to date with their schoolwork? So you're coordinating care with the schools. Any friends, when kids are separated from other kids, that they don't like that. They wanna be surrounded with that. COVID has drastically limited visitors and who can visit kids, so that's been very challenging. Okay, questions there? No. I'm going to briefly talk about this. I don't want to spend a lot of time here, but things that have changed in pediatric nursing. Prevention of medication errors. We're seeing this even in the adult world. What do you have to do? You're verifying your patient. You scan their bracelet. You're scanning the med. The computers are alarming you if something's not right. All of that was put into place because at some point there were continuous breakdown in the process and people were having no errors. So this has been shown to significantly decrease that, right? Opportunities added to the curriculum. I was fortunate when I went to nursing school, I had a great pediatric rotation. I went to school in St. Louis, so I went to a pediatric hospital. But think of other schools or people that you may know in other schools, they're probably not getting the exposure to even take care of pediatric or laboring moms in their nursing school. So just that we feel very fortunate that we're able to be able to do that. Lots of education for families, which we will talk more about, and there has been a significant decline in infant mortality. because of lots of evidence-based stuff. Okay, let's talk about what does mortality mean, first of all? Death, right? So why do you guys think it says infants under 1 year old? Why are infants under 1 year old dying? What do you think? Okay. What else?
Maybe
Under 1.
incorrect safety routine of the parents, like.
Okay, what do you guys think about children born with some sort of genetic or congenital anomaly that's not compatible with life? That's probably one of the main reasons children under the age of 1 are dying. Okay, some sort of congenital issue. Let's say they make it to 6 months, but under 1 year, so under 12 months, so 6 to 12 months. What do you guys think children are dying from that in that age group? So you guys said SIDS, right? What else? Accidents, right? Major things that you're gonna hear though are suffocation. People are putting stuff in their bed that should not be in their bed. They're playing with things that they shouldn't play with and they suffocate to death. Motor vehicle accidents and drowning in this age group. Okay? Over 1, why are they dying? Any ideas? Somebody said falls, this is gonna be in this age group. Falls are huge in children over 1. So accidents, which would, whether that be intentional accidents or accidental accidents, falls would fall under that. Not baby proofing the home. What does that mean?
Like outlet.
Okay, a baby gets into a chemical and that can be deadly, right? Maybe what else? Baby proofing. What would that encompass?
Outlets.
Outlets, maybe they get electrocuted to death. We hope not, but it could happen. What else?
No baby gate around the pool.
Huh?
No baby gate around the pool.
Right, no baby gate around the pool, no baby gate over the stairs, they fall down all the stairs, they have a traumatic brain injury. What do you guys think about blinds, cords, those types of things? They could hang themselves? Okay. Other things, toilets, tubs, anything with water, kids gravitate towards water. And they can easily drown in just inches of water, okay? Your school-age children, they actually have the lowest rate of death, yay for that. They're dying from motor vehicle accidents, bike accidents, ATV accidents, skateboards, so on and so forth. Adolescents, for your teenagers, right? Why are they dying? What do you think? What do they start doing at this age?
Driving.
Driving. They start driving the car and they are invincible and I can go as fast as I want and I can do whatever I want and I can text and I can talk on the phone and I can do Snapchat and I can play with the radio all while I'm driving my car. No, you can't, but you think you can, sure. So driving, huge. What else in this age group? Riskier behavior, drinking. Those are good thoughts, not what I'm thinking. Suicide. And then homicide in this age group. Who do you think, what sex is this affected more? Male. More than female. Okay, this talks all about family-centered care, which you guys will learn to know that families are extremely vital and important in the pediatric world. There will be families who cannot be at the bedside, and I think that really shocks you guys as students, is when we show up and there's a baby in the bed and there's no family there. And you guys are like, well, what the heck? Why are they not here? You guys I know that's very hard. It is hard for me to wrap my head around, but I also try to give people grace because you have to think about people. There are a lot of, I feel like most of us, we have food on our table, right? We have transportation to get here, we have running water at home, we have a safe place to sleep. You have to think about these people who are single families or maybe don't have a job or maybe working 3 jobs to try to support their family. They can't be there 24 hours a day. And so we have to give people grace. They have 6 other kids at home that they're taking care of. So how are they as a single mom supposed to be at the hospital with 1 kid and they have 5 other children at home? So I really tried for you guys to think outside the box and not jump to conclusions and be totally judgmental about people. And we're just there to take care of our kids, so that's the one good thing about pediatrics is I'm here to take care of your child. Sure, I don't really care what else you got going on. My sole goal is to take care of your kid and to send them home to a relatively healthy place the best I can. Okay, we recognize the family is consistent. Kids are very loyal to their parents. They will love mommy and daddy no matter what happens, and I can promise you that. Develop nursing care to include the family. How do we do this? How do we include family if we're at the bedside?
Show them if they like, if the kid has like, I don't know, like for instance that burns or something and they need aftercare, like teaching them how to.
How can they, teaching them, okay, when I give the bath, you can help me with X, Y, and Z, right? Or after, let me get you set up so you can help feed the baby. Or let me show you, I know they have all these wires connected, but you can still help change the diapers. Let me show you how that might look a little bit different, but that you can still help. So just incorporating them and showing them how they can help. A lot of times, this may be the first time their kid's ever admitted to the hospital and they're terrified, right? There's alarms going off, there's wires everywhere. It's completely overwhelming, so they just feel like, I can't even touch my kid. But just come over here, like, you can hold your kid, let me do this first, and then let me help you get him on the bed. So just helping coordinate that type of stuff. That's good. The next slide says atraumatic care. What's that mean?
Not having traumatic care.
We try to reduce the amount of trauma when we're providing care to kids, right? So we will use different interventions to eliminate or minimize physical distress, whether that be for the child or the family. How do we do that? Any ideas? Okay, what else can we do?
Allowing the child to stay with their family.
Yeah, allow the family to say, hey, we're gonna get ready to do an IV. I always tell families, would you like to stay in the room or would you like to step out? More times than not, they want to stay in the room. This is what you can expect. We're gonna clean their arm, we're gonna put a tight rubber band on, we're gonna stick a needle in their arm. They're probably gonna scream and cry. But we need to get this access for the IV antibiotics or the IV fluids or whatever. Okay? Other things in pediatrics that you'll see is they use a lot of like numbing creams or those types of things prior to procedures to try to make things more comfortable for kids. The other thing is we use a lot of distraction. We get very creative. And most pediatric hospitals have something called a child life specialist. Anybody heard of that? Any ideas what that is?
Aren't they just like the one that comes in and like basically distracts them and knows how to like entertain them while you do what you need to do?
Sure. Yes. So. Try to
It
distract.
was terrible stuff. Yeah, my sister had one when my nephew had to get surgery on a hydrocell or whatever that's called. Is that the- Yeah, whenever they did that, there was one of those there too. And that's solely their job, isn't it?
Yeah, so they have a really cool job actually. Okay, first of all, let's just think about this. In the adult world, we're gonna go in and put a 90. How long do you think that takes? Roughly. That's a good estimate, 20 minutes. We're gonna go in and put a 90 in a child. An hour. At least, if not longer. Do you think that you have, let's just say an hour and a half. Do you think as a nurse caring for 4 to 5 patients that you have an hour and a half of your day to do nothing but put a 90 in? No, you really don't. So, what these wonderful, fabulous people do, sorry, I need to switch the slide. What they will typically do is you're gonna call them, or some of them work directly on your floor, you'll kind of figure that out if you work in pediatrics. You're gonna call them, hey, I have a patient in room 5, they're gonna need an IV, I need to get it in as soon as possible. They'll usually kind of tell you what they've got going on. They're gonna go in the room and they are gonna completely explain everything to that child. And so basically when you walk in with all of your supplies, you get to solely focus on the skill of placing the IB. Now, that doesn't mean you get to blatantly just ignore the kid. You're still gonna help walk them through that, but that person is already gonna have coached them through what to expect. You're probably gonna stay for the procedure, help try with distraction and that type of stuff. So they help make your job a lot easier, so you need to treat them very nicely, okay? What do we do? So basically, when you go in there, that family and that kid is already aware of what to expect that saves you a tremendous amount of time.
I'm Laura, and I'm a child life specialist. A child life specialist is someone who works with our patients and their families to really help them cope with the hospital experience. When patients are having medical procedures, it's a strange environment with strange people. They're uncomfortable, they're scared, they're worried. One of the things that we can do is help educate patients before a medical procedure, let them know what they might experience, and then walk them through some coping techniques so they can be successful. We might also use distraction tools like iPads or other games to give them something else to focus on. I think people most associate us with play, and play is really important. In fact, often there's a saying that we make healing look like child's play, but play is only one small component of what we actually do. Child life specialists work very closely with nurses, doctors, and other therapists. We all cooperate to make sure that we're really meeting all of the needs of the patient and their family. I knew I always wanted to work with kids, but when I first learned about child life, I knew immediately that it was for me. All child life specialists who want to be certified need to have coursework in child development and child psychology. We also need to have an internship where we're studying under certified child life professionals. It's important to be compassionate, to be empathetic, but to also be a little bit flexible. You kind of never know where your day is going to take you. I think one of the cooler things about my job is that I'm actually able to be present with patients when they're going back to have surgery or when they're in the middle of a medical procedure. The best is when a child will actually thank me after their procedure, when really they're the ones that did all the work and I just help them through it.
What a cool guy. Questions? No? No, quiet.
How frequently do you feel like it turns into just having to do children? Like procedures?
Yeah,
I was just guessing that was it.
depends, I would say it depends on the age of the doctor. Yes. Okay, evidence-based care, you guys are in research. I am not gonna spend any more time on this, other than I think it's important that we are lifelong learners. I can tell you, when I came out of school and did certain things certain ways, it has already changed since, when did I graduate, 2011? So things have drastically already changed since then, so just being open to new ideas and that knowing that your practice is gonna be ever changing, okay? Health promotion and disease prevention. We already talked a little bit about this. So in kids, we're talking about nutrition, we're talking about vaccines, we're talking about growth and development, we're talking about safety, which we will talk more in depth about. Okay, types of families. First of all, what is a nuclear family? Mom, dad, children, right? They live together in one house, right? What is extended family? Great, grandparents, aunts, uncles, other people related by blood that provide social, emotional, or some sort of support to that kid. Okay? Multi-generational, what is that? 3 or more generations of relatives. Keep it simple, 3 or more generations. A non-biological parent family. These are your, go ahead.
Step-parents.
Good thought. These are your kids who, are in foster care or some sort of kinship type of care. Then you have blended families, that is when parents are divorced and remarried, that's where the steps come in. Okay. And cohabitating, this is where you have the divorced families as well. Maybe dad has a girlfriend with kids, but they're not actually married. So there's a difference between blended and cohabitating. Blended, dad and mom are divorced, dad and mom are remarried to different people, and there's steps of blended home. Cohabitating, mom and dad are divorced, mom and dad have boyfriend or girlfriend with kids in the home. Does that make sense?
So is it the only thing if they're just not married with that one?
Yes. Okay, single parent should be self-explanatory, right? Okay, homosexual families, that's gonna be your same-sex, couples raising children. Bi-nuclear. This and blended are very similar. Bi-nuclear means that both mom and dad are both remarried with stepchildren. Blended could mean that only mom could stay single and dad got remarried and has kids. I don't want you guys to get too stressed about this. When you're studying this, just have a general understanding. If you were to read the kid has a blended family, you know what that means. Or the kid is in a homosexual family, you know what that means, okay? Why is this important? Why do I even talk about this?
Just know this, it's all.
How do their lives are all different?
Okay, so it's part of their lives. Why would it be important in the hospital setting?
Custody.
Custody, huge, okay? You may have a child who is in state custody, but is in physical custody of the family. What does that mean? I'm gonna say it again. The child is in state custody, but is in physical custody of the parent.
Foster kids?
Good thought. Let's say it's a biological child. Let's say my daughter is in my physical custody, but the state also has custody. What that means is my child physically lives with me, but I make no decisions about my child. The state of Missouri makes all medical decisions for my child. Okay? That happens, you're gonna see that. And that is usually because has been some sort of issue in the family. Maybe I was a drug addict, I got my child taken away, they have come back to me now. I've proved that they have a safe place to live, but I haven't proved that I'm capable of making good medical decisions for my child yet. Okay? So let's say that kid has to go for a procedure. Let's say my daughter comes in, I have physical custody, the state has medical custody, she needs an appendectomy.
Consent from the guardian.
The state of Missouri will give consent for my child to get surgery. You are correct. I cannot sign that. That was probably a bad example because that's more of an emergency. They're gonna get the appy out, but if I were just coming in for it, maybe she needs to get a PICC line. The state of Missouri is gonna have to get permission for my child to get a PICC line. I cannot do that. Does that make sense?
What process, does that make the process longer to get that?
It's usually that kid will have a social worker,
Okay.
and they're usually dealing with more of the behind the scenes social work, caseworker. Usually they'll have a caseworker for the state of Missouri, and that person should be able to say, yes, this kid needs a PICC line for life-saving antibiotics. I'm gonna go ahead and give permission for that kid to get it, but there's still a delay. It's not like I can go in and, oh, we can get her in 5 minutes if you can sign this. There's still gonna be some delay there with the communication and getting back and forth to people, so yeah. Obviously, if it is life or death, they're gonna, yeah, do it and then get whatever X permission they
Because
need.
even life or death for us sometimes consent.
Yeah. Yes. Okay, questions about that? So, you guys don't just willy-nilly give out information to whoever is in the room, correct? Okay.
still give,
Yes, typically the parents can have information.
They just can't make decisions.
Correct. And you can't just assume if there is a male and a female in the room that that's mom and dad. So if the child is old enough, it's rude when you come in and it's like, well, who are you? That sounds rude, right? I'd be like, well, okay, lady, like, I'm the mom, what do you mean, who am I?
Who are you?
Yeah. So I usually, if the kid is old enough, I'll say, who's here with you today? That sounds a lot nicer than, well, who are you? And the kids are usually like, oh, that's my aunt, or that's grandma, or that's mama, that's, dad, whatever. And so then you kind of can roll with the punches from there. If you are unsure, it is wise just not to say anything. I can think of many times working in St. Louis where people assumed it was mom and dad, but actually it was mom and some boyfriend, and then dad showed up, and it just gets very, very ugly. Well, he can't have information, and you guys gave information, and it becomes a whole debacle. So, just protect yourself and be cautious, okay? It will tell you in the chart when you are prepping who that kid, if there's any custody concerns, it should be very clear in the chart, okay? Other things I think about, restraining orders. So mom and dad, mom may have a restraining order against dad, vice versa. So we have to be cognizant of those types of issues and try to coordinate that care for that kid. Some parents will have supervised visitation. So they have rights to see their child, but they have to be supervised while visiting their child. So you may be coordinating with social work. I know dad's coming at 4 p.m. today. Who's gonna be available to help supervise the visit with him? So, I know that will fall into you. Okay, discipline. What a beautiful, ugly, hard thing to do as a parent, right? So this is the best advice I can give parents, is to be consistent. So if the behavior isn't what you have deemed between mom, dad, mom, grandma, whoever takes care of the child, I don't care. Everybody's gotta be on the same page. So if little Johnny is not allowed to play by the fireplace and I'm watching him, I know that when he goes to play by the fireplace, this is what mom or dad is expecting. So babysitters need to be involved in this as well. Whoever is involved with the care of your child, everybody's gotta be on the same page. So being consistent, each time the behavior is incorrect, that you're using that same discipline. Timing, so you can't say, you wait till your dad gets home and he hears about this. It's not gonna do you any good. They're gonna forget 3 hours from now what they did was wrong. So you have to discipline in that moment, okay? Commitment, you're actually gonna follow through. So if you don't stop throwing rocks at your brother, I'm gonna take the TV away for a week. I'm making this up. And then they throw the rocks again. I told you if you throw the rocks, and if you throw it one more time, I'm gonna take TV away from the week. Then they throw the rock again. This is the parent that continues to say that, but never actually does it. That kids are not dumb. They start to know, well, mom's never actually gonna do that, so I can still get away with it. So just actually following through with what you say you're gonna do. Flexibility, so discipline that is appropriate for the child's age and developmental level. What do you guys know about timeout? That's a common discipline. So you should know.
1 minute for every age.
Every year they are.
Yep, so 1 minute for every year of how old they are. So, here's the key, the timeout doesn't start until they actually start behaving appropriately. So, if they're 3 years old, how many minutes of timeout do they get? 3 minutes. So, if little Johnny is screaming for his 3-minute timeout, that doesn't count. It starts when little Johnny has got himself together and he's acting appropriately. That is when the 3 minutes start, okay? Questions on that?
I have a question. What about, so, let's say you put your kid in timeout and then they're throwing a fit, do you start it over? Or do you keep it going?
So they're throwing a fit and they stop and you start timeout. And then you're a minute and then they start having a tantrum again.
Okay.
That's gonna be your parental judgment. I would start over.
Okay.
I would say, sorry, 1 minute down, you got 2 left, buddy, you better straighten up. I don't know, I would start over. Planning, everybody's gotta be on the same plan, I already said that, and then privacy, I think it's important that we're not disciplining them in front of a full room of people. If you're taking them, if you're in a restaurant, you're pulling them outside the restaurant. Look, if you don't sit in that chair and eat your dinner, then this is what's gonna happen, I'm gonna give you one more chance, right? And then executing whatever you said was gonna happen. Okay? I think the hard thing is let's think about children. They go to school, or they go to daycare, and then people pick them up. Roughly what time do you think? 3:30 to 5 o'clock probably, right? And they've been, what do people do after work? They may have to go to the store to get food to prepare for dinner, right? Okay, and we know after kids have been at school, they're what? They're tired, they're hungry, their brains have just, whoosh, they don't have anything. So this is what happens, they go to the grocery store and what happens? A complete meltdown, right? They're hungry, they're tired, I see something I want and I can't have it, and it just unfolds. So I try to tell parents to try to anticipate. Like, you know that going to the grocery store after school with little Johnny, it ain't gonna work, right? It's not a good idea. So maybe you could run to the grocery store before you pick up little Johnny, and then you could go straight home and fix dinner. So just trying to, and it doesn't always work perfect and beautiful. Going to the grocery store when it's nap time is not gonna go well, right? He or she's used to sleeping at a time. They're gonna have a meltdown at Walmart. So just being a parent and anticipating some of these things, okay? I've taken my daughter to Walmart and she had a complete meltdown. And it was probably very poor planning on my part when I look back on it. So I'm not to say that I am innocent of any of this. It is not easy being a parent and figuring out what works and what doesn't work. And certain things work for certain people. But if you can anticipate a little bit, usually it goes a little bit smoother, okay? Yeah, yeah.
I kind of understand.
Just parking.
Yeah.
I have to melt down before I even go in, yeah, I understand that. The pickup's nice though. Okay, communication, I gotta speed it up here, okay. Some of this should be a review from health assessment, asking broad, open-ended questions. You don't want, when you're talking to families, to just get yes or no answers typically. You want more information. You want to actually listen to people. Talk with the family, get to know the family. Remember I said trust is huge. And then on here, silence may indicate families need to slow down. They don't want to be pushed to ask if there's anything you want to say. So you will know when I don't know. As you're a nurse, you'll start to be able to read people's behaviors pretty well. I can tell when a parent doesn't like what I have to say, or maybe they're starting to shut down a little bit. And so then I'll usually say, I'll just call out, like, you look really upset. Is there something I can clarify, or do you have questions for me? Are you not happy with that plan? And then that gives them the ball to where they can say, yeah, I'm pissed because you're not gonna give me an antibiotic for my viral illness. Yeah, that's what I'm mad about. And so then that, needs more education. That was just an example, or I'm just feeling very overwhelmed because you're telling me I have to miss work tomorrow, and I know if I miss another day at work, I'm probably gonna lose my job, or whatever. Those are just examples I can think of. So, but I think it's important that we acknowledge that. Don't just ignore it. Like, okay, well, have a great day. I think it's important that we have those communications with people. Though they can be very awkward at times. I don't think it's on this slide, but I like to tell you that you're never gonna promise a child something that you're not actually gonna do. Okay? So when you're at the hospital, if you tell a kid, I'm gonna play the game with you before I leave tonight. If you're gonna play the game with them before you leave, you're not just gonna have words that have no meaning, because kids never remember that stuff. Well, you said we were gonna play, well, when are we gonna play? Every time you go in there, they're probably gonna ask you that. So please, 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 do not promise anything that you cannot follow through on, okay? Things we've already talked about, you're gonna get on their level, you're gonna make eye contact, you're not gonna be hurried or rushed. You're gonna incorporate dolls, puppets, animals. If they have a little kid, you're gonna see this probably when you're in the hospital. If you take your stethoscope and go for, I would say anybody under 3 directly for their chest, they're gonna freak out. What are you doing? They're gonna have flashbacks to when they got shots or they got a swab at some point, whatever. So I always say, okay, I'm gonna listen. Let's listen. How does mommy or daddy sound today? Mommy sounds really good. Oh, Miss Mindy sounds really good. Okay. And then usually by that point they know, didn't hurt mommy, didn't hurt Miss Mindy. It's not gonna hurt me when she puts her stethoscope on me. Okay? That's just an example. Offer choices only when they exist. Okay. If you ask a kid, do you wanna brush your teeth? What are they gonna say? No. Well, I really need you to brush your teeth. No. Can you please brush your teeth? No. How are you gonna get that kid to brush their teeth? So I need to brush your teeth? No. 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 Nope. I'm not doing it.
So you wanna brush your teeth now or in 10 minutes?
You wanna brush your teeth before your snack or after your snack? You wanna brush your teeth before you put your clothes on or after you put your clothes on? So they're still making a choice, but you're still getting to the end goal. So, and pick your battles. That's my advice to you, okay? Pick what battles are really important to you. Be honest, you're gonna allow the child to be themselves. You can learn a lot about a kid by sitting down. Why does it keep doing that? You can learn a lot about a kid by 5 minutes sitting down, coloring and talking with them, or reading them a book, or anything. Just slow down and take that extra 5 minutes, okay? Communicating per age. So, infants, they can only see so far, correct? Little babies. So, this is a baby. Hi, little baby. How are you? What do you think about this world? Oh my goodness, you're so cute. Right? Hi, fish boys. Really, really good. Hey, baby. I'm happy. Okay. What do babies love? They love to be held. Oh, you're so pretty. You know, whatever. Children less than 6, we need to be very simple when we talk to them, be very specific. What do you think, how do you think this is going to go? I'm going to take, I wonder if I still have that picture. I'm going to look at my phone like that, sorry. I'm going to take your blood pressure. How do you think that's going to go over? What are they going to think? You're gonna take something away from me. So I'm gonna give your arm a hug. I need to see how big your muscles are. Whatever creative little saying that you come up with. I had a perfect. I still have it. Let me just go back here. It was a posting with a doctor. It was so good. I'll try to find it for you guys and post it. I'm wondering if I still have it. Okay, I'm gonna see if it's on the slide. I'm gonna put it on there. Quiet voice, allow them to touch your equipment, provide choices when you can, you're gonna be honest, you're gonna use play. Remember, children take your words literally. That's what I meant when I'm gonna take your blood pressure. Taking something to take it back. Your school age kids, they wanna know everything. Well, when you squeeze that blood pressure cuff, how does it work? What do you mean you can hear my, well, how do you hear my blood pressure? They wanna know all of that. They wanna be included, they wanna answer your questions. So when they're there to see, they wanna talk, they don't want mom or dad to talk, they wanna tell you what they're doing. Your adolescents, this is a very difficult age group. If you don't have a good rapport with them, it can be very hard to take care of them. Okay, they can be very defiant. Make sure your expectations for them are clear. I had a patient, he was a CF patient, and he was, so that cystic fibrosis, he was in and out of the hospital every 3 months, he'd come in for weeks at a time. He never liked the morning, and I always got to take care of him on the day shift. And he would never want to get up and take his medicine, and I'd always say, look, if you just wake up and take your pill. You can go back to sleep until lunchtime. I don't care, but you have to take these pills with me. And every morning we would fight, and it was just like, oh, I said, you know what, I'm gonna tap shoes in here, and I'm gonna tap on your floor until you wake up, if you don't wake up and take these pills tomorrow. And so, what do you know, showed up the next day, wouldn't wake up. So I was like, well, I don't have tap shoes, what am I gonna do? So I went, you know, like the little leads with the metal on the bottom? So I went and taped them all over my shoes. You know, tapping away, he's like, you're crazy! I told you I was gonna do that. So from then on, he was, you know, she's gonna show up and do something crazy. I better take these pills. So he took the pills. And he's a great kid. He's doing great, but teenagers are tough. Privacy, huge. If you were gonna ask them about sex, drugs, anything risky, I always say, I have questions I need to ask you. Would you like mom or dad to stay in here, or would you like them to step out? I give them the choice. Sometimes if I can feel the tension between a parent and a child, I will just ask the parent to step out. Hey, I'm gonna need you to step out of the room. I have some questions I need to ask. Those parents are usually already pretty high strung. How do you think that goes over? Now.
Do they have to be a certain age for you to ask if you're on
What's the age?
In the state of Missouri, any child over the age of 13, I do not have to tell your parents anything unless, here's the caveat, it involves the safety of you or the safety of somebody else. So if they want to kill themselves, they want to kill their mom, something up, they're being sexually abused, they're doing IV drugs every day, that's a severe risk to their health. Something like that, I will have to tell their parents. I'll tell them that. Look, whatever we talk about is confidential, unless it involves the safety of you or the safety of somebody else, I will keep what we talk about confidential. However, keep in mind, you are on your parents' insurance. So anything that I order or prescribe, they are probably gonna find out. And so then I will offer, do you want me to help you have the difficult conversation, or do you want to deal with that on your own? So.
What, like, for kids, like, social, 11, 12 years old, where the parent always be there in that situation, when do you cut off the parent being present?
I don't know that I ever cut it off.
Okay, when would it be, okay, like, for instance, I have a friend who, like, her 11-year-old was having an exam, they asked her to step out of the room, and she, like, felt like that was appropriate, because her daughter was 11. Is that?
There are gonna be times when we will separate kids from our parent, or from their parent. I remember when I broke my arm, I was probably, 8 or 9. And I remember them separating me from my mom and asking me what happened. And it's usually if there's not, they weren't suspecting that my mother abused me, but we always have to take caution when it comes to like something traumatic like that, or anything in the genital area. A lot of times we may ask parents to step in or out, especially if we're suspecting that maybe we're missing something or there may be more to the story. I don't know exactly what that situation was, but those are times I can see them really separate. Not intentionally accusing anybody of anything, just making sure we're not. Yep. Okay, we got kind of derailed there. Any other questions? Okay, so privacy is big. This slide is a 35-minute video about growth and development. If you choose to watch it on your own time, great. I am not gonna sit here and let you watch a 35-minute video. It is just an extra resource for you, okay? What factors influence growth and development? Let's talk about this quickly. Nutrition, what else? Genetics, who said that? Huge, genetics. What about the environment that children grow up in? Think it matters?
Yes.
Definitely.
Sis.
Yeah, I think it's heater. Yeah.
It's a heater.
Okay. So genetics, environment, culture, right? Culture. I think that has a significant impact on people. We talked about nutrition. We talked about just their health status in general, family. That's a good start. This I'm gonna skip for now. This slide is here because I wanted you to know what is a newborn, what age is that Disney right now? A newborn?
28 days.
Birth to what? Birth to 28 days. An infant is birth, or I should technically say it's 28 days to 1 year. Whatever. You're probably gonna hear infant more than anything. A toddler, 1 to 3. A preschooler, 3 to 6. A school age, 6 to 12. An adolescent, 12 to 18. Y'all should know that for the first exam. If I say toddler, you should say 1 to 3. If I say school age, you should say 6 to 12. You have got to know that knowledge like this for the test, okay? That would be the intention of that slide. The Erickson stages, this should be a review for you also. Trust versus what? Good. This is your infants. Autonomy versus what? Shame and doubt. This is your toddlers. Initiative versus guilt. This is your preschoolers. Industry versus inferiority. This is your school age. Identity versus role confusion. This is your adolescence. I'm going to talk more about that in early development. That's all I'm going to say. This should already have been something you've been looking at, correct? This is, I covered in Super Lab, a pediatric assessment. There is a video there. It's about 6 minutes long, I think. If you want to watch it, you can. If not, I covered a very detailed assessment, I think, in Super Lab. Okay. Let's do a little quiz. Dun, dun. When should a child be back to birth weight?
2 weeks.
And should they double?
6 months.
And they should triple. Their height should double by when?
It should increase by 50%. Double by 4 years. Yeah, double by 4 years.
And it should increase by 50%.
1 year.
Good job. Going in. The only thing I want to mention here, we talked a lot about all of this, U.S. custody, should be at the bedside, blah, 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 is it helps if the kid's going to be hospitalized for a while, have the parents bring something in that's theirs, their favorite blankie, their favorite stuffed animal, their favorite pillow from home, something to make them a little more comfortable. And it's okay to tell parents they can bring that stuff. Okay, sometimes they think it's just such a different atmosphere, they're timid or scared to do that. This here, I'm not gonna spend a lot of time on, but there are different developmental screenings that different pediatricians use. The Denver 2 is a little bit more old school. It is still being utilized by some. Some are using an ASQ type of developmental screening. Basically, any developmental screening, what are we looking for? What did you say? So we're looking at their development, their fine motor, their gross motor, their language, their social behaviors. And we're looking to make sure they're at what age they should be at. Are they below, are they above, or are they on target? These screening tools are done to try to catch children who are falling behind so we can get them the resources that they may need. Okay? Questions? This is milestone stuff. It gives you the textbooks, it gives you the tables. You guys have got to start becoming familiar of at what age children are doing what. At 2 months, a baby is cooing. At 6 months, we can anticipate maybe a tooth is gonna come through. They should not have any head lag at 6 months. What does that mean? Okay, I take a baby and I have them flat on the table and I take their hand and I pull them to a seated position. If their head is like this, they have head lag. If a 6-month-old should be, their head should come up with their body. Does that make sense? Okay. month, they should be able to take an object and go back and forth. Okay, those are just examples. 15 months, they should be able to walk on their own. What did I say, 15 months? Yeah, on their own. That doesn't mean earlier they're walking with someone's hand, but by 15 months, they should be on their own, taking off. Okay? We'll talk more about that. We talked tons about newborn reflexes, immunizations. We have a whole PowerPoint on. Nutrition, I will talk about with each developmental, with my growth and development today. So I'm gonna skip that slide and I will make sure I get my notes on that as well. Types of play, I will talk about again with growth and development, but you guys have gotta start becoming familiar with what this means. What is solitary play? What is parallel play? What is associative play? What is cooperative play? Anybody know, what is solitary play? By themselves. They lay around and look at the mirror, or they're doing some activity by themselves. What is parallel play?
Next to each other.
Right. Me and Katie are sitting by each other. We're playing in the sandbox, but we are not playing together. Clear? What's associative play? Okay, they play together, but there is absolutely no organization at all. Okay? And then cooperative play. This is where we have roles. I'm the mom, you're the dad, you're the baby, you're the grandma. So there's a little bit more organization, and we're kind of cooperatively playing together. End goal, this is where kids are playing sports, those types of things as well. We're gonna have pain, so I'm gonna skip this, okay? What is safe sleep? So we're gonna review this. On their back, supine, right?
Nothing in the bed with him.
Nothing in the bed with him. They are not co-sleeping. There is no bumpers. There is no quilts. There is no pillows. There is no fancy comforters. There is no stuffed toys. And safe sleep also includes that they're in mom and dad's room, correct? Not in mom and dad's bed for the first how long?
They should do it for a year, but 6 months.
Y'all study. I love it. Safety, I am not gonna expect that you know anything about car seats because it is an ever-changing thing. I will expect that you know that children are to be rear-facing in a car seat until the age of 2. Okay? What about, why do kids wear helmets?
To shoot
Yeah, well, we have, we're talking about safety here, so we're not talking. So we will talk about that today. Helmet wise, so like a kid that's riding a bike or an ATV, they should always have something that protects their head, okay? Toys, this year is a website about recalled toys, it's just for your information. How do we know toys are inappropriate, are appropriate for the child?
Depending on the age of the child and the size of the toy.
Make sure there's no little pieces of it.
They're listed, generally.
Usually it'll say on the box, right? 6+ months, 1+ year, whatever. Are you laughing at yourself?
No, I can't, every time I look at this, the toy stuff, I'm old, you're gonna remember, do you remember the old Saturday Night Live skit where he's like, oh, bag of toys, we've got a bag of glass here? Remember that? Oh, it's hilarious, you should look it up, it is, I non-stop laughing. I can't, every time I think about the development, I just can't not laugh. Just think about Dan Aykroyd hacking a bag of glass to a 2-year-old.
Yeah, that's great. Yeah, no, I'll have to watch it Saturday Night Live. I'll find it. Okay. Then this was, see, this lecture is usually on the first day that I see you because I think pediatrics is the best. I mean, it's literally, the only adult experience I had is when I was a tech and then straight out of nursing school, I went into peds. I knew I wanted to work with kids. I originally went to school to be an elementary school teacher and then I changed my major to nursing, but pediatrics is the best. I hope that you are all excited. It is okay to be a little bit scared. I am here to tell you that I'm not gonna put you in a situation where it's uncomfortable. If we have high-strung, needy
over the top parents. I am not gonna put you in a situation where we have to pass meds with him, because you're already gonna be stressed out enough, that I'm not gonna put you in a situation like that, okay? So if I ever tell you, yes, we're planning to pass your meds, but we're gonna feel out the parents, that's what I mean by that, okay? And then I think this is from Grey's Anatomy, it's beautiful. This is not general surgery in miniature. These are the tiny humans. These are children. They believe in magic. They play pretend. There is fairy dust in their IV bags. They hope and they cross their fingers and they make wishes. And that's what makes them more resilient than adults. They recover fast, they survive worse, and they believe in peace. We have miracles and magic and peace and things possible. So, any outstanding concerns about going into pediatrics that I can try to alleviate for you? No? Alright, great. You need a break? Take a 5-minute break and we'll cruise forward. Class is important. When you are studying, this is many chapters of information. I try to tell you what I think is most important, short, sweet, to the point. So if I mention it in class, you should probably go and read it in your textbook. I am not telling you to go read the hundreds and hundreds of pages that the compass program. Are we clear? Okay. You guys have to realize that there's a ton of information, and I only, because for such a small period of time, I can only tell you the most important things, or what I think that they are the most important. Okay? Alright. So, growth and development. We are going to talk about newborn all the way. We kind of talked about the newborn. So this is from the newborn infant to your adolescent age. Okay? So, the first slide is all of these beautiful little, what's wrong?
Nothing. Do you have that on? No, it's there.
I'm just showing you that on our slide.
You do understand this, so does it
It's
show
over
it?
there.
It's cause
Yeah,
they're
wait.
white and it's
Does everybody
shades of
else have
black.
that?
Yeah,
You're
it's
showing-
it looks exactly the same. Theirs is just.
On campus stuff?
You show.
So some of you can see it.
Most of us can see it except for these.
Can you download it on your?
No, like it doesn't even
It's
show it on the
because the thing
campus.
switched to a white background and the wording is white, so it's
Oh.
white on white.
On campus, no.
But my refrigerator.
I'm trying to go to my brain.
Here, I'll just send
I
it
need
to
to give
you.
you guys a
Please.
minute.
No,
Just
you're
give me
fine.
just a second. Let me try to send it to you really quickly. I'm gonna have to pay for this one. This sucks.
What if you try to use Simply?
I am, right now.
Okay. I'm gonna start talking.
Maybe this is why I should have started with that.
Okay, this slide are some important milestones that you need to know. There's no way around it, you have to know it, okay? So, things at 2 months that you should be seeing. What does it mean when I say a baby smiles socially? You are able to make them smile as a parent, right? Oh, you're so cute, and they smile, or whatever you do to get them to smile. They're gonna take their hands and they will put their hands to their mouth. They should be saying little noises. They should be able to take a rattle between 2 and 3 months and at least, not like go crazy, but at least shake it to where they can make noise, okay? 4 to 5 months, they will roll from their abdomen to their back by 5 months. Abdomen to back. Now I want you to skip down here. They will roll from their back to their abdomen at 6 months. Why do you think they go from their belly to their back first? Okay, first of all, I want to preface this with every kid is different. What I am teaching you is what the AAP, your textbook says that the majority of kids will go in this order. So if you've had children, you've kind of got to forget about when your child is what, because it probably won't follow perfectly with this. But why do we think kids go from their belly to their back first? Okay, so it's easier, doesn't bring as much muscle. What else? Think about their head, it's very heavy.
So it's easier to go, just basically fall over, rather than you're sitting this way and you kinda gotta get enough to move your entire head the other way. Does that make sense? Okay, so I think it's important to know that. One is at 5 months, one is at 6 months. What else? 6 months, they should start maybe imitating a little bit of what you're saying. Like, for example, when the dogs bark at my house, what does my daughter do? So she'll hear the dogs bark and then she'll go, oh, 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 like a dog. It's like, oh my gosh. It doesn't exactly sound like the dog, but you know she's imitating it, okay? Here's an important one too. They sit with support. At what age? Sit with support. So that means if I take the baby and I sit them here on the desk at 6 months, I kind of have to have my hands around them. They're gonna hold their head because they shouldn't have head lag at 6 months, right? Now, when will I be able to remove my hands completely and they're gonna sit there by themselves? Okay, by 8 months, they should be able to sit by themselves without my help. We talked about head lag, we talked about transferring. 9 to 10 months, they're gonna pull to stand and they will start to cruise. What does that mean?
They crawl.
Okay.
Or in some way.
So if I'm a little kid and I pull up on the desk and I'm holding on and cruising, they're gonna cruise along the furniture. Okay, that's what it means. Pull up and cruise. Okay, and that's when? It says they're gonna use their thumb and their index finger for the pincher grasp. Okay, so if I take her little cereal or whatever she's eating and put it in my hand, that baby between 9 and 10 months should grab it out of my hand with these two fingers. And on the other side. Okay. We'll start to say mama, dada. Now it's not gonna sound like that, mama. It's gonna be like mama, 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 mama. It's not gonna be perfect and beautiful. Sometimes you gotta use your imagination to do that a little bit. And they're gonna start to learn the meaning. So they're gonna know I'm mama and he's dada. Okay? They definitely know what no means. I'm in that phase right now. No. Slap your hand, no. Pout and cry because you know what no means. We don't give them enough credit. 12 months, it says they're gonna walk with one hand held. So I'm gonna hold baby's hand, and at 12 months, they should walk through the classroom. Okay? They're gonna try to start standing by themselves and probably walk. They're gonna start drinking from a cup. They can say 3 to 5 words. Now these aren't complicated. It's probably like no, up, mom, dad, maybe yes. That's probably all you're gonna get. And then they should be able to sit down from a standing position. So if baby's standing, they're probably gonna squat and then fall on their butt. Okay? This here says they're in Erickson's stage of trust versus mistrust, which is birth to 1 year. What does it mean, trust versus mistrust? What do you guys think? So they are relying on us. So what do babies do when they need something? They cry. And they usually cry because what? Like what? They're hungry. They need their diaper changed. They're in pain. They want to be covered. So that's how we build trust with them, is that we respond to their communication or their cry. What if we don't respond to them?
If we're crying,
They will kind of go towards that mistrust, right? And basically their basic needs aren't being met. Okay? Let me make sure I'm telling you everything I need to mention. What do you think if they head down the mistrust because we're not responding to them? We're not meeting their basic needs. What do you expect will happen to this child? Developmental delays, they may start to have failure to cry. They're not going to start achieving things of their trust. Questions on this slide? No? This should be a review. I'm not going to sit here and tell you again, but you know, you have their birth weight back at 2 weeks. What should they be at 6 months, 12 months? Same with length.
I am going to allow you to put a line through head circumference. I expect that you know how to obtain a head circumference. Everybody is clear on that. And we measure it in what? Good. I do want to say one thing about it. When do you expect to see the most head growth? Here's your options. First 3 months, 4 to 6 months, or after 6 months? When do you see that baby's head grow the most? First 3 months. Think about how much a baby grows in the first 3 months. Then it starts to taper down a little bit. Okay? Anybody know the average birth weight? 7 pounds, 8 ounces. What's the average length? 19 to 21 inches. Okay. Tell me what you remember about the posterior and the anterior fontanelle. Okay, what is this up here? The anterior fontanelle closes when? 12 to 18 months. Posterior fontanelle, tinier, triangular in size, closes when? Typically 3 to 4 months. I'm sorry, 2 to 3 months. 2 to 3, 12 to 18. Which one's bigger? Which one's smaller, triangle shape? Good. Reflexes, again, they appear. That I'm talking about them. Might they be important? Good. When do we expect them to disappear? What did we say?